Module 7, Dose Optimization, Patients and Staff. Take some time to look through the learning outcomes for the module. In terms of knowledge and understanding, we hope that you will have an understanding of the cone beam CT equipment factors that can be adjusted to change the radiation dose delivered to patients. We hope that you will understand the relationship between radiation dose and image quality and how optimization methods may affect diagnostic efficacy. We hope that you'll have an understanding of the factors that determine radiation dose received by staff. In terms of skills and abilities, we hope that you'll be able to optimize the exposure factors for individual patients. We hope that you'll be able to source evidence-based advice on minimizing staff dose, this being particularly relevant to the dentists undertaking this module. And particularly for physicists undertaking this module, we hope that you'll be able to provide practicable evidence-based advice on minimizing staff doses. The overall judgment and stance for this module is that we should strive for the lowest practicable radiation doses for patients and staff, consistent with adequate image quality. In previous modules, we found that the radiation doses in cone beam CT are typically larger than with conventional dental imaging, but smaller than with medical CT. Many variables can influence the effective dose, producing opportunities for optimization. The ICRP established three fundamental principles for radiological protection: justification, optimization, and the application of dose limits. This concept of optimization is therefore absolutely central to radiation protection. It's important to put this in the context of European directives. And the Council Directive 97/43 Euratom on health protection of individuals against the dangers of ionizing radiation in relation to medical exposures stated that all doses due to medical exposure for radiological purposes, except radiotherapeutic procedures, shall be kept as low as reasonably achievable, consistent with obtaining the required diagnostic information, taking into account economic and social factors. The key phrase here is as low as reasonably achievable. This is commonly referred to as the ALARA principle. The Council Directive also stated that the optimization process shall include the selection of equipment, the consistent production of adequate diagnostic information or therapeutic outcome, as well as the practical aspects, quality assurance including quality control, and the assessment and evaluation of patient dose or administered activities, taking into account economic and social factors. In this module, we'll be dealing very specifically with the selection of equipment and equipment exposure factors. In the next module, we'll be looking more closely at quality assurance. In terms of practical optimization, for example, in a dental practice, there is no one individual whose responsibility it is to consider how to maintain a dose as low as reasonably achievable to patients and staff. In reality, it is a shared duty between various people, including the owner of the practice, the dentist or medical practitioner who takes responsibility for an individual exposure, and the medical physics expert who provides support and advice to a dentist in looking after their cone beam CT equipment. When we think about CBCT dose parameters, and particularly in the context of patient dose, there are three major parameters which can be influenced by different factors. First, X-ray quantity and quality. Second, the field of view size. And finally, the use of shielding. Let's look at each of those in turn, starting with X-ray quantity and quality. X-ray energy quantity and quality is determined by three factors: kilovoltage, commonly abbreviated to kV, the exposure, which is a product of the current and the exposure time, commonly referred to as MAS, milliamps times seconds, and finally filtration. Before we look at the effects of these exposure parameters on X-ray dose, it's important to consider that X-rays used in X-ray equipment are not monoenergetic. If you look at the graph on the right, very simplified graph, you'll see on the vertical axis the number of X-rays, in other words their quantity, and on the horizontal axis their energy, in other words their quality. The graph shows a single line, in other words all the X-rays are the same energy. This is not the situation in diagnostic X-ray equipment. In reality, they produce a range of energies corresponding to the curve that you see on the graph on the right. This is called an X-ray spectrum. You'll see that most of the X-rays have an energy in the middle of the range, with fewer weak X-rays and fewer strong X-rays. Let's look at what happens when we change MAS, kV, or filtration. Well, if we increase the MAS, we will get an increase in the total quantity of X-rays, but we don't change the quality. The range of energies remains exactly the same. The peak of the curve remains in the same place. If we decrease the MAS, the same result occurs, that we don't change the X-ray energy spectrum, but we do reduce the quantity of X-rays produced. In other words, the current and the exposure time change just the quantity of X-rays. In fact, these two factors, current and exposure time, are described as reciprocal factors. If we increase one and decrease the other by the appropriate amount, the actual exposure can remain exactly the same. What about kilovoltage? Well, if we increase the kilovoltage, the effect is to not only increase the quantity of X-rays, but also their quality. You will see that the curve is now moved to the right, both in extent, and the peak of the curve has also moved to the right. If we decrease the kilovoltage, the effect is to change the shape of the curve as shown here. The peak of the curve moves to the left, and the maximum energy also moves to the left. In other words, the kilovoltage changes both the quantity and the quality of the X-rays. What about filtration? Well, remember that filtration constitutes aluminium filters placed over the X-ray source in order to remove weak X-rays. So if we increase the filtration, we will actually reduce the overall quantity of X-rays, but we will actually move the peak of the curve to the right and therefore increase the mean energy. So we are changing also the quality of the X-ray spectrum. If we remove filtration, we will increase the quantity of X-rays but move the peak of the curve to the left, therefore reducing the mean energy of the X-ray spectrum. In other words, filtration changes both the quantity and quality of X-rays. How does this affect optimization in the real world? As far as kilovoltage is concerned, there is a large variability in dental CBCT equipment. Some units operate at 70 kV, others may operate as high as 120 kV. The kilovoltage is often fixed by the manufacturer, and only some cone beam CT machines offer the potential to optimize the kilovoltage for different clinical situations and patient sizes. An important factor to consider, which we'll explore later, is that changing the kilovoltage will also influence the image quality. What about tube current and exposure time? Remember I mentioned that tube current and exposure time were reciprocal factors. Thus, if we keep exposure time fixed, there is a linear relationship between the milliamperage, the tube current, and the radiation dose. The milliamperage is often user-defined in cone beam CT, obviously within certain limits set by the manufacturers. As far as exposure time is concerned, for a fixed tube current, there is a linear relationship between exposure time and dose. Although it may seem that exposure times are fixed on cone beam CT equipment, it can be user-defined in some cases when we change the number of basis projections. This is often seen in terms of exposure factor selection as a resolution setting. And in some equipment we can also alter the extent of the rotation, for example from a full rotation to a half rotation. In both these contexts we are actually changing the exposure time. It's important to remember also that changing these parameters will influence image quality, as we will see later. Changing the number of basis images, as I said, will alter the exposure time used, and this means that if we use fewer basis images, we will use a lower MAS and reduce the overall dose to the patient. This will influence the image quality. The two images you see here are cone beam CT scans of the temporomandibular joint. The image on the left was taken with a full rotation, the image on the right with a half rotation. Thus, half the MAS was used in the image on the right. Interestingly, the image quality is not, subjectively speaking, much different, and this emphasizes the potential we have to reduce the radiation dose to patients when we're carrying out routine examinations. What about filtration? Well, this is the parameter that is least likely to be adjustable by a clinician using a cone beam CT piece of equipment. It's invariably fixed and already optimized by the manufacturer. In theory, it would be possible to add additional filtration, and if we were to do this, it would lead to a loss of image quality. But this would only be achievable by the work of engineers and medical physics advice. Just out of interest, look at this survey of 6 months workload in a hospital-based CBCT unit. This is shown for examinations that were performed using a small volume cone beam CT. You will see here that the operators of the equipment did choose to adjust the kilovoltage and the MAS for patients according to their size and age. Thus you'll see that for children, or at least young people under the age of 21 years, the kilovoltage used was lower than that for adult patients. Similarly, the milliamperage was reduced compared with adult patients. Manufacturers sometimes recommend a single exposure, a single kilovoltage, a single MAS for all patients. What this survey indicates is that there is scope for reduction of these factors. One very important way in which we can optimize the exposure to the patients is by limiting the field of view size to the volume of interest. There's a steep drop in the dose outside the primary beam. Limiting field of view may also offer the opportunity to avoid crucial organs. And of course, the organs to avoid, if possible, would be the thyroid and salivary glands. Indeed, this parameter is of such importance that the European Academy of Dental and Maxillofacial Radiology included in their basic principles on the use of cone beam CT this statement: CBCT equipment should offer a choice of volume sizes and examinations, and must use the smallest that is compatible with the clinical situation if this provides less radiation dose to the patient. Let's look at a very typical example in clinical practice. This patient had impacted lower canine teeth. The clinician needs to know whether or not there is resorption of the roots of the erupted incisor teeth before deciding on their treatment plan. Here, a small volume cone beam CT scan has been carried out, and this scan gives us all the information we need to proceed. On the other hand, with equipment that offers large fields of view, to use that large field of view for that particular patient would have been completely inappropriate. Large fields of view should be restricted to very selected cases, such as here. Close examination of the 3D image may give you some indication of the asymmetry in this patient's jaw, and if you look at the axial scan, which is shown on the left in rather a small size, you will see again the asymmetry of the facial bones relative to the cervical spine. An interesting factor relevant to staph dose, which we'll be coming on to later, is that large volumes also give greater scattered radiation. What about resolution and voxel size? Well, spatial resolution is related to the exposure factors used. Some CBCT equipment gives you an option of a high resolution scan, and people may choose to select this on the basis that it can't be wrong to have the highest resolution. It's important to remember that high resolution usually means higher dose to the patients, and you should always ask whether or not we really need this high resolution. High resolution is usually achieved either through increasing the MAS or using more basis images. The size of the reconstruction voxel is also closely linked with spatial resolution. The EAD-MFR basic principles on the use of cone beam CT stated that where CBCT equipment offers a choice of resolution, that resolution compatible with adequate diagnosis and the lowest achievable dose should be used. In other words, high resolution options should be very cautiously and carefully selected because of their dose implications. Finally, in terms of patient optimization, the use of lead shielding. Lead shielding is useful for primary radiation and potentially for external scatter. However, in dental cone beam CT, probably the only practicable application is protection of the thyroid gland, and you see here some different designs of thyroid shields. Siklakis et al. In 2005 demonstrated using a large volume cone beam CT scanner that a dose reduction was achievable using thyroid shielding. However, it is probably the case that where small volume scanners are concerned, with good limitation of the field of view, well away from the thyroid gland, that use of shielding is not absolutely essential. Similarly, there should be no need for abdominal lead protection in cone beam CT, as the primary beam should not be going anywhere near the abdomen. Nonetheless, we recognize that national legislation may be such that there is a need for the use of lead protection for some dentists. So far, we've concentrated very much on the influence of these exposure factors on radiation dose. But we should never consider dose in isolation. We also have to consider quality. and it's crucial to understand the effect of different exposure parameters on the resulting image quality. Exposure parameters may influence the spatial resolution, the contrast, and the noise in the image, as well as artifacts. The images you see here are of a plastic phantom into which are placed objects of different density. Why are we doing this? Well, this is to illustrate in an objective way the influence of exposure factors on image quality. In this case, let's look at the influence of changing the kilovoltage on contrast and noise in the image. The picture on the left was exposed at 90 kilovolts and with 5 milliamps. The picture on the right shows the same object but taken using an 80 kilovoltage exposure. You may be able to perceive some slight change in image quality here. Now the picture on the right was taken at 70 kilovolts. Again, maybe you're starting to see a little bit of change of image quality, a slightly more noisy image, in other words, a slightly granular looking appearance. Perhaps with some loss of contrast when we look at the individual objects placed into the plastic phantom. By the time we reach 60 kilovolts, I think we probably all appreciate the slightly granular, noisy image and some loss of contrast that's seen in the objects placed within the phantom. Nonetheless, what is particularly interesting is that we can still perceive detail. Now, this is a long way from a clinical situation, but it does suggest that we may be able to reduce kilovoltage in clinical practice and accept some loss of image quality, as so long as that is still compatible with an adequate diagnosis. Let's look at the influence of kilovoltage using images that are more applicable to clinical practice. Here we have 4 images from Conebeam CT datasets, each taken at a different kilovoltage, from 75 through to 90 kilovolts. In each case, the MAS was exactly the same. On this machine, 90 kilovolts is the recommended kilovoltage for use in patients. If you look at the top left at the 75 kilovolt examination and compare it with the 90 kilovolt examination, I think you will perceive some increased granularity, some loss of resolution. Perhaps this shows better if we magnify the images and just look at a small portion of them. Nonetheless, if you look at the 75 kilovolt Conebeam CT examination, we can still perceive quite a lot of detail. While this is not telling anyone to reduce all their exposures to 75 kilovolts, it does suggest that there is scope for reducing this exposure factor while maintaining adequate diagnostic quality. Let's now look at the effect of milliamperage, or indeed exposure time, on contrast and noise using this phantom. In this case, we will change the milliamperage, but remember, of course, that if we were able to change the exposure time, we would get the same results. The picture on the left was taken at 90 kilovolts and at 5 MA, the recommended exposure for this particular machine. The picture on the left and all the subsequent pictures are also taken at 90 kilovolts, but with a reduced milliamperage. Here at 4 MA, you can see very little difference in the image quality on the phantom. At 3 MA, again, not a great deal of difference is observed in the image quality. By the time we get to 2 MA, I think we can perceive some granularity, some increased noise in the image, and perhaps some loss of clarity of the objects of different density placed within the phantom. By the time we get to 1 MA, that's 1/5 of the exposure of the image on the left, you can indeed see a significant granularity of the image, a noisy image. Once again, however, this illustrates how in clinical practice perhaps we could get away with a much lower exposure while still maintaining adequate quality. And this perhaps is also seen here using the anthropomorphic phantom, where we have bones and teeth set into plastic and exposed using different exposure factors, ranging from as low as 27 MAS for the image on the top left to 154 MAS, the picture on the bottom right. Incidentally, 154 MAS was using the recommended exposure factor of the manufacturer. If again we magnify certain of these images, you will see that when we use very low MAS, there is certainly on this example a significant loss of image quality. But nonetheless, once again, it illustrates how we may be able to reduce these exposure factors in clinical practice, maintaining an adequate image quality by reducing the dose to the patient. One factor that does limit our possibilities for reduction of dose by reducing the exposure factors is the presence of artifacts. In cone beam CT, artifacts are frequently a problem from metallic restorations in the patient. The images you see here were produced on the phantom that I've described before, made of plastic, into which is inserted metallic test objects. This allows us to look at the effects of changing the exposure factors on the artifacts. In this case, the image on the left is a full rotation image, and the image on the right is a half rotation image. In other words, taken with half the exposure factors. What is often seen when we reduce the exposure factors in cone beam CT is that the artifacts become more prominent or more obvious to the eye. And this will obviously be a limiting factor in how low we can reduce the dose to the patients. Similarly here, where we're comparing images produced at 90 kilovolts, that is the recommended for this particular machine, on the left, compared with 60 kilovolts on the right. Once again, you can see that the artifacts remain particularly prominent, but set against a background that has low quality. So if we summarize patient protection, there are several parameters that determine the patient dose associated with a cone beam CT examination. Some of these can be adjusted by the operator, such as kilovoltage, milliamperage, and perhaps exposure time. Some are fixed by the manufacturer, for example in some machines the kilovoltage, certainly the filtration, and some can be changed with the advice of a medical physics expert. An important point to get across, though, is that there's always a trade-off between radiation dose and image quality. And the difficult choice will always be identifying the appropriate compromise. Having looked at patient protection, let's now move on to protection of staff. The employer's responsibilities for staff protection are twofold. First, to ensure that all staff receive radiation doses below dose limits, and second, to ensure staff dose is as low as reasonably achievable, the ALARA principle. The employee's responsibilities for staff protection are as follows: to take care to limit their own dose and the dose to others, to comply with the employer's instructions, for example local rules, to use any protective equipment provided, to report defects and to return it to store correctly, not to misuse or tamper with equipment, and to report incidents. What factors affect staff doses? Well, the primary beam in cone beam CT is considered to be fully attenuated by the patient and the detector, so this is not our primary concern as far as staff doses is concerned. Rather, our concern is scattered X-ray dose which is the main contributor to occupational exposure. And this varies significantly with different cone beam CT units. An important concept to understand is that all the factors that influence patient dose can also influence staff dose. For example, all the exposure factors of kilovoltage, MAS, field of view size, full or partial rotations, and so on. This is because increasing the exposure factors to the patient results in increased scattered radiation that potentially may expose the staff member. So obviously, keeping the doses as low as reasonably achievable to the patient benefits radiation dose optimization to the staff member. Practical control measures then, starting off with something very simple, is minimization of the time for which the staff members are exposed to the source of radiation. Distance is also a key factor in protection, because radiation decreases with distance according to the inverse square law. Doubling the distance from the source of radiation will quarter the radiation dose received. In practice, however, using distance as the protection measure for members of staff with cone beam CT in a dental practice is insufficient, and we need to rely on the use of appropriate shielding in barriers and other shielding devices between the operator and the X-ray source. In order to calculate the shielding required in barriers, we need to consider the following factors: any relevant dose constraint that has been set, the workload in that particular cone beam CT facility, the particular dose rate per scan, remembering that different cone beam CT machines produce different amounts of scattered radiation, and a worst case scenario is usually used in determining the need for shielding, the tube voltage, and the likely distance that's going to be between the barrier position and the patient. Now clearly these are things that should not be determined by a dentist in an ordinary dental practice, and input from a qualified medical physics expert is absolutely mandatory. Just out of interest, here's an example taken from a United Kingdom Health Protection Agency report. 2.24 millimeters of lead is needed for a dose constraint of 0.3 millisieverts, with an X-ray machine operating at 120 kilovolts and assuming 40 micrograys per scan, with the barrier placed at half a meter away from the patient. Clearly, this would vary significantly depending on the piece of equipment used, the size of the room, and the likely use of the equipment in the practice. But it gives you an idea of the sort of calculation that needs to be carried out by the medical physics expert. For high dose rate machines particularly, distance as a radiation protection measure is therefore not practical. And for worst case scenarios, all people except the patient needs to stand behind protective shielding. It is a good idea to have warning lights and signs installed outside the room where the cone beam CT examination is being performed. And for machines which require software authorization, the computer should be placed in such a position that the operator can maintain full view of the cone beam CT room. Where exposure switches are placed outside the room, they should be key controlled to prevent unauthorized use. Personal monitoring is often carried out by dentists and dental staff. How relevant is it to cone beam CT? while the need for personal monitoring must be considered in the prior risk assessment. And indeed, national guidelines and regulations may in some instances require the use of personal monitoring. But in situations where personal monitoring is not mandatory, if the operating situation is such that an exposure cannot be initiated unless the operator is standing behind a shielded door or window, then in that case only occasional monitoring is suggested. In any other situation, for cone beam CT, routine monitoring is recommended. So to summarize, staff must have received adequate training. Patient dose optimization should help with staff dose optimization. Policies should be established that eliminate staff risk from radiation. And shielding is likely to be required with cone beam CT installations. A very important point to complete this module is to consider that involvement of a medical physics expert prior to equipment installation is essential to optimize staff dose.